It's Tim from ChiroUp. We're here with Kara today, and we're going to talk about heel pain, one of the most common presentations. So our patient comes in, they have pain when they walk, especially on hard surfaces. We have a lot of things in the differential. Could be plantar fasciitis, it could be a heel pad syndrome, it could be a calcaneal stress fracture, or even a neuropathy. How do we differentiate? Let's talk about the exam. First thing we have to do, the patient do a heel drop test. They come up on their toes and drop down. That's going to hurt things that are locally irritated. The mechanics of heel pad syndrome, plantar fasciitis, or certainly a calcaneal stress fracture. It's probably not going to be overly provocative in somebody who has a neuropathy, whether that be a tarsal tunnel or Baxter's. The next test that we can use is simply having them walk on their toes. Somebody with heel pad syndrome, irritation in the inferior aspect of the calcaneus, feels better when they get their heel off the ground, whereas somebody with plantar fasciitis, because of the windlass mechanism, we're tractioning that plantar fascia when they're up on their toes. It doesn't feel any better than when they're walking on their feet. The next thing that we can do is use our hands. So we have the patient lie down and palpate the area of discomfort. So we take the patient's leg up, we'll support it a little bit, and if I poke on the medial aspect of the calcaneus, there should be, number one, a springiness to the area. That a healthy heel pad should be about 2 centimeters thick and it should be springy. If we feel atrophy, we're suspicious of the heel pad syndrome. Secondly, when we poke the center of the calcaneus, if that causes pain, that again indicates heel pad syndrome, whereas we know most of our patients with plantar fasciitis have their pain a little bit more in the medial inferior aspect of the calcaneus as opposed to the central aspect. The next thing that we're going to do is find out, does the calcaneus itself hurt? So if we suspect a calcaneal stress fracture, we can do a squeeze test where we're compressing the medial and lateral aspect of the calcaneus far on the outside, away from where the plantar fascia irritation is, and if that causes pain, now we're suspicious of a calcaneal stress fracture. And the last things that we want to differentiate are the neuropathies, that we all know what to do for a lumbar neuropathy, or a lumbar radiculopathy, I should say, but the peripheral neuropathies of a Baxter's neuropathy or a tarsal tunnel syndrome would be evaluated more locally. So for a tarsal tunnel syndrome, where the posterior tibial nerve is irritated, we're going to have pain in the arch and pain into the heel itself. So the way that we'll do that is the same thing we do for any other peripheral neuropathy. We're going to stretch it and we're going to compress it. Think of phalans and reverse phalans. So to stretch it, we're going to take that patient's foot into some dorsiflexion eversion while extending their toes and holding that position 10 to 15 seconds, and with that ischemia saying, is there reproduction of discomfort? If that's not enough, let's add some compression. So we put that patient's foot into the dorsiflexion eversion test and now add some compression over the posterior tibial nerve. If that triple compression test isn't positive, probably not a tarsal tunnel syndrome patient. And the other sneaky condition that we want to watch for is Baxter's neuropathy. That's irritation of a branch of the posterior tibial nerve that comes underneath the calcaneus, the inferior calcaneal nerve. It supplies the heel and the arch. When it's irritated, it looks very much like plantar fasciitis. The one differentiating maneuver here is that the inferior calcaneal nerve also innervates the abductor digiti minimi. So a patient with Baxter's neuropathy is often not able to provide resistance, that those toes just go together when we squeeze on them, as opposed to Kara, who's able to hold their toe out really well. So we're not suspecting a Baxter's neuropathy. I hope that this information helps you differentiate heel pain. There's lots of possibilities and they're all treated differently. If you'd like to learn more about the number 2 cause of heel pain, which is heel pad syndrome, 10 to 15% of the population suffers from this at some point in their lifetime, and 15% of all plantar heel pain patients have a heel pad syndrome. We've done some homework on that one. Our advisory board, with the help of Dr. Tom Mashad, have put together a protocol on heel pad syndrome. We hope that you'll check it out. We've detailed a little bit in the blog. Otherwise, go into ChiroUp.com. You'll be able to reference that condition report as well as all of the other condition references of the things we've talked about. Hope you've enjoyed this, and we look forward to connecting again in the future.